Thank you for everyone coming in today. We're really privileged to have Dr. Rob Weller speak to us today. So Rob is a general physician and had nearly 2 decades worth of experience in helping people with ME CFS. And so Rob is going to run through a presentation today, and would love you to pop in any questions that you have, and we can come back to those. And I have a few questions as well. So at this moment, what I might do is hand it over to you, Rob.
Thanks, Nathan, and thanks for the opportunity to speak. Just by way of a bit of background, I'm actually a rehabilitation physician rather than a general physician. Apologies. And I've been doing this work on a more formal basis since about 2003, when we were getting increasing numbers of referrals from Lana Lubitz's paediatric program at the Austin. That led us to set up our own program, and we've been doing that for 17 years. But as some of you may have heard more recently, that program's now gone into indefinite suspension, partly because of the COVID crisis and partly because I'm in the process of retiring and the hospital doesn't think they'll be able to find somebody with a similar interest. So we have been running an interdisciplinary program on an outpatient basis, and we've seen quite a lot of people over the years, but we haven't had a big research profile. So I should just say that at the outset. It's been mostly about clinical work, and we've looked at our numbers from time to time, but not really on a formal research basis. The other thing I want to say at the outset is that I firmly believe that this is a real condition. I just want to get that on the table, because there's a lot of people in the health industry who still don't think that it is a real condition. So what I'm proposing to do now is run through the presentation that we give to patients who are referred to us as part of the entry process into our program. And it's a group information session that's designed to give people a sense of where our program is coming from and what we understand by chronic fatigue syndrome and what our approach to management of the problem is. So I'm assuming everybody can see my screen. Is that right, Nathan?
Yes, that should be the case. If anyone isn't, then please let us know if they can't see. And as again, please type in some questions as we go along as well.
Okay, so chronic fatigue syndrome, I still call it that because I can't get my head around the systemic exertion intolerance disease thing that seems to be the most recent agreed name for it. So I'm going to keep calling it CFS for the time being. And let me just figure out how to change my slides. There we go. So what I'm going to run through is 6 questions. What is it? What isn't it? What other conditions do we see more often in people with chronic fatigue syndrome? What do we know? What don't we know? And where to from here? So starting with what is it? It's tempting to think of this as yuppie flu and something that's only just become fashionable, but it was actually first described by a guy called George Miller Beard in 1869, and he called it neurasthenia. And if you look at that list of symptoms on your screen, a lot of those look like chronic fatigue syndrome, and he thought it was due to the stress of urbanisation and an increasingly competitive business environment. That might give you a bit of a sense as to the sort of patients he was seeing too. We have a number of different sets of criteria that really talk about what the syndrome looks like, and the Fukuda criteria or the CDC criteria is probably the one that's in most common usage. And that talks about an illness that has been clinically evaluated and unexplained and has been present for at least 6 months. It has to be something that's of new onset, in other words, not something that you've had forever, and it doesn't result from ongoing exertion and doesn't go away when you rest. And then we like to see at least 4 of those other symptoms that you see on the screen. Cognitive problems, sore throat, tender lymph nodes, especially in the neck, muscle pain, joint pain, new onset headaches, unrefreshing sleep, and post-exertion malaise. And post-exertion malaise is probably the critical thing, and some of the other diagnostic criteria sets say that you really have to have that to get a diagnosis of chronic fatigue syndrome. And post-exertion malaise, the other fashion term for that now is post-exertion neuroimmune exhaustion, or PENE. So that just means that all of your symptoms pretty much get a lot worse after any unaccustomed activity. That can take 24 hours or so to come on, and it can last anywhere between a few hours and a few weeks. So I mentioned other sets of diagnostic criteria, and these are probably the most well-known ones. The Oxford is a bit simpler than the previous Fukuda criteria that I talked about. The Canadian and international consensus criteria came out in the 90s and the early noughties, and are much more complicated and a bit harder to use in a clinical setting because they pretty much describe every symptom that you could think of. The paediatric criteria are similar, but the only major difference is that they don't require you to have had the problem for 6 months. They talk about 3 months. So going on to what it isn't, and what I mean by what isn't it is that chronic fatigue syndrome, as you probably know, is a diagnosis of exclusion. We can't do a test that says this is definitely what it is, but we need to do tests anyway to rule out other things that can cause a similar picture and that are treatable and important not to miss. So if you look down that list, there's some things that are pretty obvious. If you're anemic, you're going to feel tired all the time because your red blood cell count is low. There are some medication side effects that can produce similar pictures. We always want to see thyroid function tests because underfunctioning of the thyroid gland can produce fatigue and poor energy and aches and pains. Excuse me. And the other important one is primary sleep disorders, especially sleep apnea. And that's the reason why often we will send people to a sleep specialist to have those things ruled out because it's important to treat them. And then there's a number of psychiatric conditions that can also produce a similar picture. And top of the list is depression. People who are depressed have trouble sleeping, have fatigue problems, have trouble getting interested in things that they want to do. And the trouble sleeping in turn can lead to muscle aches and pains. And the thing that complicates it, as a lot of you will know, is that if you can't do the sorts of things that you want to do because you have chronic fatigue syndrome, that in turn can make you depressed. So that's a very difficult one to tease out sometimes. And sometimes the only way to tease it out is to trial antidepressant medications. It doesn't mean we think that everybody is depressed and that chronic fatigue syndrome is depression, but it's just about treating the things that we can treat. What other conditions are seen more commonly in patients with chronic fatigue syndrome? It's a big list. I guess the biggest ones that we see quite often are fibromyalgia or generalized muscle pain and irritable bowel. So a lot of people with chronic fatigue syndrome seem to have problems with their gut. And I think that might be a bit of a pointer towards the possible causes of the problem. Some of the other things are a bit harder to understand. I'm not quite sure why people with chronic fatigue syndrome should have mitral valve prolapse, which is a cardiac disease, more commonly than other people in the community, but that's what the data says. Likewise, Hashimoto's thyroiditis, the last one on the list there, is a primary autoimmune thyroid illness. And that one, again, is important to pick up because it's treatable.
And just in that list there, Rob, I noticed that orthostatic intolerance or POTS is not on that list.
Yep.
How often do you see that in your cohort?
We do see that in the cohort quite often. It was on that list, but I took it off the list deliberately because there's been some literature recently suggesting that it's not more common in CFS than it is in the general community. So I guess it's important to recognise it if it's there because there are things that you can do to address it, but it's not cut and dried. It's not clearly more common in CFS.
Great.
According to that review paper anyway. So what do we know? these are the things that we are pretty definite about. The main age group affected is people between 20 and 40, and it affects women much more often than men. We know that it's not a fatal disease, despite a lot of the stuff that you might have read on the internet. And we know that kids recover better than adults. So the complete recovery rate in children can be somewhere north of 90%, but we don't see numbers anywhere near that in adults. We don't know why people get it, but we suspect that because it's a fairly non-specific group of symptoms, that people might arrive at that group of symptoms from multiple different directions. In other words, there might be a lot of different causes that actually result in the same kind of presentation. And that itself might be one of the reasons why some of the treatments that are being trialled don't work, because or they only work in some people and not in others because the underlying cause is different. We know that all of the investigations that we generally do to try and look for treatable conditions are normal. We know that, generally speaking, diets and supplements and a lot of medications don't really help, and prolonged rest certainly doesn't help, because that then introduces all of the things that come secondary to immobilisation and deconditioning. What don't we know? We don't know why people get it. And as I said before, there are a number of theories. People talk about occult infections or latent infections with things like herpes viruses and chickenpox. And there's a guy in the States who goes around the conference circuit showing electron microscope pictures of viruses embedded in cells in the gut. Excuse me. I think there's a fair bit of support for the idea that the underlying problem is an immune system problem, and that it's related to the gut because, as you may know, the gut is the biggest immune system organ in our bodies. So it is responsible for weeding out the allergens and the bugs in a lot of the things that we eat, and mounting the primary immune response to those things. And you can imagine that if there's a problem in that area, then that's going to cause problems further down the track. There's a theory around that it's about the neuroendocrine axis, and that's you may have heard the term adrenal dysfunction or adrenal hypofunction or adrenal fatigue. That's what that diagnosis is talking about. There's a position statement from the College of Physicians that says there's no such thing as adrenal fatigue, so they don't believe that's a real diagnosis. But some of the testing can show that serum cortisol levels, for example, steroid levels in the bloodstream that are created by your adrenal glands, fluctuate through the day in normal people, but don't fluctuate as much. There's no rises and falls in levels in chronic fatigue patients in the same way as there are in the general population. A lot of this stuff that shows up on the tests, though, is it's not clear whether what you're seeing is a cause or whether it's just an association with the condition. There are still people around who believe it's primarily psychological or psychiatric. And as I said, sometimes depression is a tricky one to try and tease out how much of the presentation is due to that and how much of it's due to chronic fatigue syndrome. And there's a suggestion too that there's a genetic predisposition. So we can talk about predisposing factors like your inheritance, and then precipitating factors like an infection, and glandular fever is a common precipitant, and then perpetuating factors, which is really about how you respond to what's going on in your body and what you do about it. Sorry, I don't know if I've got a cough button on the computer, but if there is one there, I haven't found it. So where do we go from here? The things that we know are helpful. The first thing is recognizing that the illness is real and having some understanding of the problem. And part of that's about educating patients, and part of it's about educating the health community, and part of it's about educating relatives and carers. So any approach to managing the problem, I think it's important that patients understand the problem, but also that their relatives understand the problem. We used to talk about graded exercise, and I purposely don't use that term because of the negative publicity that graded exercise seems to be getting. But I think it is still important to have some kind of graded increase in activity at a pace that individuals can manage. So there's no one-size-fits-all exercise program, and it may be that you have to start moving again at a pace that's ridiculously low and slow, but as long as you start moving, then you gradually increase what you do at a level that doesn't precipitate a crash or a post-exertion malaise episode, you're heading in the right direction. Pacing should be a familiar term to all of you, and that's really about not pushing yourself to the extent that you create a crash. And I don't know, Nathan may want to say a little more about that later. Cognitive behaviour therapy, again, is a term that seems to have copped a lot of negative publicity, but that and mindfulness and other psychological strategies, if we talk about those things, it doesn't mean we think you're mad. It means that we recognise that managing any chronic condition means that you need some physical things in your toolbox, like the graded structured increase in activity, and you need some behavioural and psychological things in your toolbox to help you manage the problem. So cognitive behaviour therapy is one approach to that, and mindfulness is another approach to that. And it's about doing things that can be helpful. We recognise that one of the important things is trying to address symptoms. So people have muscle pain and joint pains and sleep problems and mood problems. There are things that we can do about all of those symptoms, and gut problems I mentioned before as well. There are things that you can trial that are effective with irritable bowel symptoms. And the other reason that we run, well, at least we used to run this as a group program at Royal Talbot, is that we think it's important that people share their journey with other people who have a similar problem rather than seeing it in isolation. And there's a bit of a sense of belonging, there's a bit of a sense of camaraderie, and there's support that people get from relating to others who have had a similar experience and realising that they're not really in it on their own. Sorry, I'll skip the slide there. So these are my main conclusions. It is a complicated condition, and it is a condition that creates significant illness burden in the community and societal burden, even if it doesn't generally lead to a fatal outcome. There are many possible causes, and as I've said, it may be that the reason some of the treatments haven't worked in the past is because they may work in one subgroup and not in another subgroup that has the condition from a different cause. We don't have a specific diagnostic test, but it's important to exclude other conditions that are treatable and that could be responsible for the presentation. And then just because we don't have a specific treatment that can make it all go away, I wish we did, but we don't, it doesn't mean that we can't do anything. As we've shown in the previous slides, there are lots of symptoms that can be managed. There are activity levels that can be improved over time, and there are psychological issues that can be supported. And my final word is beware of the snake oil salesman, because there are plenty of people out there who are prepared to take money off you for cures that have not been proven and are often very expensive, and purely by coincidence are often manufactured by the people trying to sell them. So that's the end of the presentation. I'm happy to take questions. And
fantastic. So you might you just stop sharing the screen and they'll be able to see us a little bit bigger. Fantastic. So would love people to type in any questions. There is no such thing as a silly question. So please type them in. So thank you very much, Rob. That was really great, actually. And there's so many different pieces in there that really rings true for me. We often say we don't use the C word, which is cure. really looking at about management strategies, and that it's different for everyone, and needing to look at a lot of different factors as well. So thank you. So as I said, please pop in the questions as well. I suppose if you're going to say, because you've been dealing with this population for a while, and I know that we talked a little bit about this previously, but what do you think has been the major changes over the last nearly 2 decades, within our approach or understanding?
Probably a couple of things. One is just increasing recognition of the illness. I think there's probably a lot less people around now who would poo-poo it as a diagnosis and suggest that people are bunging it on or being lazy. And I guess that's something that happens with any illness that's invisible. If you haven't obviously had a stroke or had your leg amputated, it's much more difficult for people to get their head around the idea that you're actually sick. The other change that's happened when I started doing this, a lot of the literature came out of King's College, out of Simon Wesley's group, and it was really then all about cognitive behaviour therapy and graded exercise. And I think we've probably backed off a bit from that. I think those approaches still have a role to play, but they're certainly not the be-all and end-all of understanding the condition and helping patients manage the condition.
Mm-hmm.
I didn't mention research, but we don't do a lot of research at Talbot, but if people want a good summary of the research that's around, there was a report last year to the NH&MRC Advisory Committee, which people may have accessed, but they can if you Google NH&MRC CFS 2019, that'll bring up a link to that report. And if you look at the back end of that report, there's a good summary of all of the research that's going on internationally and what they're focusing on.
Fantastic. So what we might do is we'll actually pop that up in our tribe, which is sort of a support group, a positive support group that this will be available in as well. So we'll make sure we post that up. That's really great. Because I think I've noticed.
Don't make the mistake of printing it off though, because it's very long.
No, I think we'll save some trees.
You'll kill your printer.
Yeah. Well, I think I've noticed in the last probably 4 or 5 years a lot more research. I think, especially a lot more Australian research as well, which has been quite interesting.
Well, the thing that came out of that report too is a government commitment to put more funding towards research into CFS/ME. And I'm not sure where that's going to go with the current budget being blown out of the water by the COVID, following directly on from the bushfires. But there is a government commitment to fund more research locally.
Yeah. So we've got a few questions coming through. So Susan asked, what role does the limbic system play in initiating and maintaining the condition?
Pass.
Pass? Oh, I suppose
I have no idea. I haven't read anything to suggest that the limbic system is important in either initiating or perpetuating the condition. The limbic system, to my way of thinking, is mainly responsible for mood, and I don't know of any direct link that's been shown between that system and chronic fatigue syndrome.
What do you think about the mitochondrial research and thoughts with CFS? I think this is around Dr. Sarah Myhill.
Yeah, I think it's a promising area. I think the mitochondria are little organelles within our cells that they're basically the energy generating machine in our cells, and it's tempting to think of them as being, if they're not directly responsible, they're at least playing an integral part in the way the symptoms affect our capacity to manage day by day. So I think it's an area of research that's worth pursuing, but I'm not aware of anything yet that points to a treatment based on mitochondrial dysfunction.
And I think what you mentioned before as well, it's tricky to know whether that's cause or effect of having chronic stress on the body.
Yeah.
But nevertheless, there's some research. And I think also Paul Fisher at La Trobe Uni in Melbourne is doing some research into that currently and showing dysfunction within complex 5 of the mitochondria. So that'll be something to follow through. The next question is CFS linked with past trauma in any way?
Again, I think it's been described. I know Michael Oldmeadow, who some of you may know, has a firm belief that this plays a big part, and certainly a fair number of the patients that I've seen have had childhood trauma, but it's not invariable. And again, when I talked about subgroups before, it may be one of those subgroups that there's a proportion of patients who have that background, and that predisposes them to develop this illness. But it's not there in all of them.
100%. I think we see a lot more a history of trauma within pain, also within fatigue, but more predominant within sort of fibromyalgia conditions as well.
Yeah.
I've recently been speaking to someone from CFS RMA Support Australia, and they were saying the latest research was saying graded exercise was not good for those with CFS RMA. Could you please expand a bit on your thoughts regarding this?
I don't think there's any absolutes in this condition. I think our approach to this has been to say that we know that graded exercise or slowly increasing activity or trying to progress exercise tolerance helps a number of patients who come through the door. There are some people who either can't tolerate it or don't improve, but the current state of the art is such that we can't tell those patients from the ones who will improve with it. So our approach tends to be that we try it and we are grateful if it works. If it doesn't work, then we're back in that sort of symptom management territory where we don't have a lot else to offer. So I don't think it's dangerous. I think the worst that can happen is that you precipitate a crash. And one of the things that your program and our program does is helps patients understand that a crash is not a final event, and there are ways that you can shorten the duration of the crash and also manage your activity levels so that they're less likely to happen.
Yeah, 100%. And setback planning is an important part because life happens and the setback's an inevitable part. We need to be as careful as we can.
If you recognise that everything you do consumes energy, and you work out, you know, that working consumes energy, exercising does that, cognitive tasks do that, and you balance your activities in such a way, and that comes back to what we said before about pacing. Even if you know that you're going to have to do something tomorrow that you can't get out of, that you know is going to wipe you out, it means that you back off a little on some of the other things that you do, and you just recognise that if it does cause a crash, and survive, and hopefully reduce the duration of.
And I suppose with that as well, I think that with the exercise being dangerous, you know what, I would actually say that it can be if done incorrectly. And I think too many people are told just to go out and go to the gym or go for a run or go for a walk without the appropriate advice. And I would say that if you prescribe exercise and it consistently leads to you feeling worse, then that's not graded exercise, that is exercise.
Yeah.
And I think that even though the PACE trials copped a lot of flack for its analysis, I think if you look at, I think about 1,200 sessions were delivered by trained therapists, and there were no adverse events related to exercise within that. And I think that's a strong indication. If prescribed in the right way, then it's not a dangerous thing.
I think having that structure is important. So having the exercise program overseen by somebody who is familiar with chronic fatigue syndrome and knows when to back off and knows what's a safe level to put to people. And I think that's, again, one of the reasons why the paediatric program at the Austin worked very well. It's a lot easier to impose that structure on children than it is to impose it on adults.
Mm-hmm. Yeah. So it is a challenge, with, like, I suppose, with that. But again, if you don't feel it's the right thing for you, then it's just important to raise your voice and say no. But I don't think we should be afraid to have those discussions.
Agreed.
So there's a question, what's the best way you've seen to heal the gut?
I think when I talked before, supplements and medications not being helpful, there are things that are worth a try that are not too expensive. And I think probiotics falls into primarily irritable bowel type symptoms. I think iberogast is something that's worth a try. And there are people also who have been helped with irritable bowel symptoms by the FODMAP diet and some of those other dietary interventions that are primarily directed at irritable bowel syndrome. Again, I think it's important to bear in mind that there's not one cure-all magic bullet that's going to fix everything, but there are a bunch of things that are worth trying. And in particular, what I'd say to people is that beware of people who are recommending multiple supplements and multiple expensive medications, where they can't give you a satisfactory explanation of how or why they're working. The other thing that I would say is if you try these things for a couple of months and they're not working, stop taking them. Because we see a lot of people who are still taking stuff that have been prescribed 5 years ago, 10 years ago. They're emptying their bank accounts in the process, and the rationale for why these things are supposed to be effective just isn't there.
And definitely before taking any supplements, it's always worth speaking to your doctor or to your pharmacist just to make sure that they may not have an interaction with any medications or anything else that you'd be taking as well.
Yep.
But like, I think I agree with you 100%, Rob. I think as long as it's not harmful, give it a go and try and look at it from a scientific way. You know, try it for 6 weeks.
I don't believe in telling people to stop taking everything that they're taking, especially if there are things that they're taking that they seem to be getting some benefit from. But you know, I don't want to go into too much detail because it's hard to do in a short period of time. But when you see people on multiple drugs that seem to have no obvious relationship to the illness that they're suffering from, and the rationale for using them is kooky, then I will tell people that you know, this is something that is unproven, and you're probably not doing yourself any favours. There's no such thing as a drug that doesn't have side effects.
Yeah. So for everyone, please, if there's any more questions, please put them down. So we've covered the questions. I've got one for you, Rob. Where do you see the world of CFS RMA in 10 years' time?
That's not one that I've wrapped my head around. I don't know. It depends entirely on whether there's enough critical mass of people interested in the area and interested in managing these patients. Those programs grow, and at the moment I'm not seeing that growth. So there'll be research, and hopefully the research will identify or give us a bit more information about causes and potential treatments, and that might in turn then stimulate a bit more interest in offering therapy programs, assuming they don't come up with a magic bullet that just makes it all go away, which I think is unlikely.
Yeah, I'd agree with that. I think because it's so multifactorial, and I agree with you, I think there's quite a few different subtypes and groups. I think the best we can hope is maybe it would be great if we could knock one or two of those subgroups out, or to hopefully have even some other support or medication that can give people space to engage back in life and pace their days and grade their activity back up.
I suspect what's happening at the moment is that we're seeing another subgroup evolving, because there's a lot of talk about COVID itself leading to some kind of post-viral fatigue syndrome.
And that's just the question that came through right then from Susan. Do you think there'll be an increase in chronic fatigue syndrome from COVID-19?
Yes, probably.
Yeah. So I've done a bit of research into this, and there's a study out of Canada that looked at just under 300 people that had SARS-1. So this is a SARS virus. And I think this is just ran off the top of my head, but the thing is 120 people went who were admitted to ICU. And of those, and of the total amount, I think there was 6.6% of people that still had symptoms at 12 months after the virus. And those numbers are pretty similar to glandular fever or Epstein-Barr virus. So I would say that we're probably likely. And if you think also those predisposing factors at the moment, if you think of the biopsychosocial model and stresses, that I think just where we are and the current climate, I think that we will see quite a few more, unfortunately.
Yep.
Yeah. Okay. So any more questions? I'll give it 1 minute. But I suppose when you're assessing someone, Rob, what do you think the key messages are for them to be able to walk away from, say, that assessment?
I think one of the things that jumps out at me still is that people are very grateful to be talking to somebody who is familiar with the problem and has seen a lot of people with the problem, instead of without wanting to put GPs down. I don't think they've got the time to manage a problem like this, because it does require you to sit down for more than a 10-minute consultation with a doctor and get a good understanding of what the illness is about, what your background is, what the impact of the illness on your lifestyle is, and then what sort of things you believe are going on, and what your explanation within yourself is around what's happening to you. Sorry, I lost track there. What was did I answer the question?
Yeah, you did. So the key messages, from when someone's coming, and I agree with you. I think sometimes people...
The key, I've sort of covered them in the slides. One is that it is a real condition, and we do see a lot of patients with it, and we're familiar with the problem. Understanding that there is no magic cure, understanding that there are things that can be done to improve the way you manage the illness and the way you manage things that you need to do day to day. And I think people then get a lot of benefit from the therapy program itself and the input from therapists who are familiar with the problem. Sorry, this is the most talking I've done for weeks.
That's great. So we have one more question that's come in from Susan as well. What medications have you found to be helpful for chronic fatigue syndrome?
I don't think there are any medications that are helpful for chronic fatigue syndrome. I think there are medications that are helpful for the symptoms. So there are analgesics and anti-inflammatory medications that can be helpful for the muscle and joint pain. Iberogast I've mentioned as an option for the irritable bowel type symptoms. There are analgesics that can be helpful for the headaches. We will trial melatonin for people who have difficulty with sleep initiation. We will trial amitriptyline or tricyclic antidepressants for patients who have difficulty with maintaining sleep, and especially if part of that problem is about muscle pain. So that's a bit of two birds with one stone. Old school medication that we no longer use for depression management, but is quite often used in pain management programs. There's a little bit of support for the idea of using coenzyme Q10, and that's one that's reasonably easily available from your local chemist without a prescription. And that's about it. I don't know of any other medications that are really going to be helpful. There was a big trial a few years ago of rituximab, and there was a lot of positive press about rituximab being the magic bullet, but that in bigger follow-up trials didn't turn out to be the case. I think we have to be prepared to hear that sort of thing every time somebody comes up with a positive research result. There'll be a flurry of activity and a flurry of press about it, and I think you need to maintain a bit of healthy skepticism until you see the definite evidence that it works.
What are your thoughts on stimulant medication? Because I know that some people use stimulant medications such as dexamphetamine, modafinil.
I don't prescribe them. I'm happy to, or in the past anyway, until I started my retirement process, I've been happy to continue them in patients where there's clear evidence that it's of benefit to them, and especially if they're not taking them all the time. So there's a small proportion of people that I see or I've seen who will use those sort of medications in exam situations, for example, or situations where they have an important commitment that they know those medications will be helpful for, and they don't take them the rest of the time. I think they're certainly useful in people who have a lot of problems with daytime sleepiness, and I often see David Cunnington and the sleep physicians prescribing them for that kind of reason. But just for, they sort of, in a way, they don't make sense to me for chronic fatigue syndrome in the absence of that problem with sleepiness, because what you're really doing is taking somebody who is not tolerating increased exertion or increased energy consumption and giving them a medication that's going to fire them up and potentially lead to increased energy consumption.
Yeah, and sometimes we see that people have that false high of energy and do too much and can lead to boom and busts. And I think it's, again, that larger piece where we have to look at everything that comes into it, including pacing, including setback planning and exercise, as well as medications. Yeah. What are your thoughts on B12 injections?
Good for B12 deficiency.
Yeah.
It's a fancy chicken soup. It's not, it probably isn't going to help, but it won't hurt. Yeah.
And we've got a question from Susan. What dose of CoQ10 would be helpful? What would you say?
Whatever's on the bottle. I mean, I don't prescribe. It's one of those things that if people are taking it, I won't say stop it. There's no dose that's going to work for everybody. I just follow the directions on the bottle.
Fantastic. Okay. I think that's covered most of the things that I've got down here and those questions. So if anyone else would like to pop in a question, please do. But yeah, thank you very much, Rob, for your time today. It's been fantastic and invaluable. And I think this is going to be a really great resource. So we'll post this up within the tribe and have links to this as well. So again, thank you. It's we really need to spread the word about CFS and that it's a very real condition, that it's not psychological. And the more people can understand that, I think that the more help we can get. So it's very sorry to hear that you're retiring in some ways, but then also congratulations on that retirement as well.
Just a footnote there. It's not psychological, but there is often, if not always, a psychological component to it, as there is with any chronic illness. So one of the aims, back to the basic definition of rehabilitation medicine, is to say that any illness has medical, physical, psychological and social components to it. And if you're going to do the best thing for your patients, you need to address the problems in all of those areas.
100% would agree. And I think we want to move away from that primary diagnosis of saying it's psychological. And I know that we're both not saying that. But I often say to people that if you had diabetes, then there is a psychosocial component that goes with that as well, that you can't eat the foods that you want, you change in lifestyle, how you need to go about things. And I think that's very much the same within fatigue too.
Yep.
Yeah. Fantastic. So we may finish up there, Rob, unless you have any other closing comments.
No. I think my voice is going anyway, so.
Fantastic. So again, really appreciate it. And there's a lot of thank yous in here as well. As I said, we'll have this recording up, and yeah, if anyone else has any further questions, please, they can post them under that in the tribe, and we'll endeavour to get back to you as well. So thank you.
Thank you. Good luck, everyone.